Our next speaker is Dr. Chris Lieu. He's a medical oncologist and associate professor in the Division of Medical Oncology at CU Anschutz. And today he's going to be talking about treatment options with Lynch syndrome for patients with colorectal cancer.
Well, hello, everybody. Thanks for taking time out of your Saturday to come talk about all these incredible topics and to hear these great speakers. And sorry, you got to end up with me, but we're going to talk about treatment options for patients with Lynch syndrome and colorectal cancer. And really over the next 15 minutes, this is what we want to talk about. Just want to give you a quick background. I'm talking to the experts, I know, but some background on colorectal cancer. We're going to talk about what makes patients with Lynch syndrome and colorectal cancer different than other patients with colorectal cancer. And we're going to talk about how immunotherapy has changed the landscape for of these treatments that we offer for patients with what we call MSI high colorectal cancer. And this encompasses those patients with Lynch syndrome as well. You've already heard a little bit about it from Dr. Vogel. But, as we always do, right, we'll start out with a case presentation. And this is a real life patient, a 31-year-old female with no past medical history, presented with a 6-month history of bleeding that she saw in the toilet. And there was a palpable mass on the digital rectal exam. And so what does a colonoscopy look like? Dr. Vogel's already shown you some pretty tough pictures, right, from colonoscopies, but this is a rectal mass. And then, biopsy confirms that this is a poorly differentiated adenocarcinoma. So this is a rectal cancer. This is what we typically do. We stage our patients with a CT of the chest and the abdomen, and we get an MRI pelvis. And I'm showing you images from the MRI pelvis here on the left, showing this mass here in the rectum. And that's one of the major advances, I think, over the past couple of years, is just our ability to get really, really great images preoperatively for our patients with rectal cancer. And this really can help us inform our patients, well, this is how we'd like to, treat your tumor. And of course, one of the things that our patient, and we'll come back to this at the end, is really sensitive about is that, well, she's 31. Not only was she told that she was too young to have colorectal cancer, but now that she's got a diagnosis, how are these treatments, if we are able to cure her, impact her life going forward? In particular, what about her ability to have children in the future if we offer treatments like chemoradiation, which has a high risk of pushing somebody into early menopause? So keep that patient in mind. We're going to come back to that. So how big of a problem is colorectal cancer? Again, I know I'm talking to a very, very well-informed group, but this year alone, there'll be over 150,000 new diagnoses of colorectal cancer in the United States alone. So your risk in the general population is 1 in 3. And we also know that there are 1.54 million survivors of colorectal cancer in the United States right now. And that is an absolutely amazing number. What are some of the risk factors? There are some of these risk factors that are actually risk factors for all cancers. One that's somewhat specific to colorectal cancer is this diet high in red meats and processed meats and cooking meats at very high temperatures, which is, of course, something that I love. I love barbecue. But of course, why we're all here is this risk of family history, which includes familial adenomatous polyposis, and then, of course, Lynch syndrome, which makes up a fraction of our patients with colorectal cancer, but obviously a significant number when you're talking about over 150,000 new diagnoses every single year. These are the charts that as oncologists or as any healthcare provider, we want to be able to show you. And that is that the incidence of mortality from colorectal cancer is decreasing. And so this is what the curves look like in terms of incidence and mortality for colorectal cancer in our older population. And you want to see these curves come down over time. This is from 1970 to 2020, which is really great. Many of you in the room know that these curves are absolutely reversed in our younger population. And so you see this incredible increase over the last couple of decades in both the incidence and mortality from colorectal cancer in our younger adults, and CRC will be the #1 cause of cancer-related death in our young patient population by 2030. We are not the only country documenting this type of increase. We kind of want to think that, well, this has got to be a United States specific thing, but it really isn't. And so these countries that you see kind of called out here in Europe, even in Asia, Australia, and certainly in North America are all reporting higher rates of early onset colorectal cancer. And this is obviously something that not only has national importance, but has international importance. And again, something that this group is really well suited to improve the awareness of this major issue. So you'll see a couple of these take-home points over the course of my talk. The incidence of colorectal cancer in a young population is increasing. And, these numbers are a little bit debated, but 20 to 30% of our young patients seem to have some amount of genetic syndrome associated with their colorectal cancer. But many of these cases in our early onset patients still are without a specific hereditary cause. Okay, so you had already heard me use the acronym MSI, or microsatellite instability high colorectal cancer. We're going to talk about why that's important, because all patients with Lynch syndrome have high microsatellite instability. I want to show you where colorectal cancer typically fits in terms of the number of mutations that they see. So when you look at colorectal cancer in the series of cancers that you see here, colorectal cancer is kind of on the right side of this curve, suggesting that colorectal cancer may have a higher prevalence of mutations compared to other cancers. Why is this important? Because the more mutations your tumor has, the more your immune system is attracted to it. And so, what is the importance of mismatch repair? And again, I know I'm talking to a group of people who probably understand this even better than I do, but the way I describe this to our medical students is as simple as this. If I asked you to transcribe War and Peace on Microsoft Word with an intact spell checker, how many typos would you have? You probably have a handful, but not a ton. If I asked you to transcribe that entire book without the use of spell checker, how many typos would you have? You would have a ton, or at least I would, right? And so what happens when your body replicates DNA is that sometimes there are typos. And so your body has to be able to recognize the typo, unwind the DNA, clip it out, replace it, and wind it back up. And we call that mismatch repair. And when that's intact, you get less mistakes in your DNA replication. But when that mechanism or that spell checker is broken, you get a ton of mutations. And we kind of denote that as high microsatellite instability. So what does that mean practically for our patients with Lynch syndrome that have MSI high tumors? Well, a typical colorectal cancer will have somewhere between 30 and 70 mutations in any particular tumor. But in our patients with deficient mismatch repair, or MSI high, and this includes all of our patients with Lynch, the number of mutations can be about 1,700. That is a huge fold increase in the number of mutations from microsatellite stable colorectal cancer to MSI high colorectal cancer. So what does that mean? Erica has heard me use this analogy before. It means that you have T cells that are in the tumor that have been turned off. And the way I like to describe MSI high tumors is that you have the dance floor, which is the tumor. You have people on the dance floor. That's your immune cells. Those are all the brown cells that you see here. They're just off. Nobody's dancing. There's no music. And so really the big advance in immunotherapy for cancer has really just been to turn the music on. And I'm going to show you the class of medications that Dr. Vogel's already talked about in terms of immune checkpoint blockade. So we know that there are a lot of genomic markers now that we look at in colorectal cancer. This is where you want to see oncology go, where we're starting to divide up this pie for colorectal cancer and be able to offer personalized therapy. And our patients with Lynch syndrome that are MSI high represent a sliver of this pie. But the question is, well, if you have the dance floor, you have people on the dance floor, can we start the music? Dr. Vogel's already shown you a slide suggesting that we can turn on an immune cell by blocking this interaction between programmed death ligand receptor 1, or PD1, and PDL1. And so what happens is when that connection is made, I love this cartoon, it turns off the T cell. So this is the tumor, the pink guy here, the blue guy is your immune cell. And what happens is when that connection between PD1 and PDL1 is made, T cells asleep. This is overly simplified, I know, but this is how I see this interaction in my brain. This is the PD1 checkpoint blockade. It basically gives your T cell a hat so that the tumor tries to knock the T cell out, but fails, or you can wrap up the stick in bubble wrap and essentially prevent the T cell from being turned off. And that's all these drugs are. They're just antibodies to block this interaction. So what has that meant in real life? So this was the study, the seminal study from Johns Hopkins, which was not funded by Merck, by the way, was actually funded by a patient advocacy organization who believed that maybe there is promise of immunotherapy in MSI high colorectal cancer. And what you see here is essentially tumor shrinkage over time. When you hit 100%, it means that you can no longer see the tumor radiographically. The green are our MSI high patients. These are patients that are inclusive of our Lynch syndrome patients. And then the red are the patients that are not MSI high. So the red bars do not include any patients that, do not include any patients that have Lynch syndrome. This is not only effective in colorectal cancer, but it's effective across numerous cancers. And so you're seeing here responses and pretty incredible responses in prostate, pancreas, endometrial, you name it. If you're MSI high, you can have a pretty impressive response to immunotherapy. So what does that look like in real life? We show patients their CT scans in our clinic all the time, and it kind of looks like a jumbled mess, right? But you can kind of make out the liver here. You can make out the spine and the spinal cord here. The patient's belly is here. The patient's back is here, and they're laying on the table. Here's the patient's spleen, and you can see this gigantic mass here. And patients actually can feel this, right? She told me that she could kind of feel that tumor pushing up against the abdominal wall. After 8 weeks of immunotherapy, Dr. Vogel had talked about pembrolizumab, which is immune checkpoint blockade. That's what that tumor looked like after 8 weeks. We actually ended up removing this, and it had no active cancer in it. It was just all fibrotic tissue, scar. So the immunotherapy had managed to wipe out all of the cancer. So the questions that you want to ask, and I'll go through this fairly quickly, is immunotherapy better than chemotherapy for MSI high colorectal cancer, again, inclusive of our patients with Lynch syndrome? This was a trial that was designed to answer that question. If you have a new patient with metastatic colorectal cancer stage 4, is it better to start with chemotherapy or immunotherapy? And the curves, this is how much time it takes for a tumor to grow. And the green line is immunotherapy and the red line is chemotherapy. And there are two main take-home points from this. I'll give you three. Number one, immunotherapy is better than chemotherapy for our patients with MSI high colorectal cancer, and it's not even close. Number two, there's a tail to this curve. And what does that mean? It means patients here are living 5 years plus without having their cancer grow. And that's exciting because that's what we call durable response, a response where you don't lose the effectiveness of the drug. And that's really where you want to get to, because you don't want to get a response for a couple of months and then lose that response. That doesn't help our patients as much. And then the third thing is that not everybody's responding. And so this is an area of need. There are about half the patients that do not respond to immunotherapy. So we need to do better. Combination immunotherapy, nivolumab and ipilimumab, has also shown an incredible response rate compared to even single agent immunotherapy. And I think that this is where the field is going to go in terms of adding additional immunotherapies to overcome any resistance that might exist in our patients. So your take-home points number 2 and 3, immunotherapy is approved for use in metastatic colorectal cancer that is MSI high, again, inclusive of our patients with Lynch syndrome, and immunotherapy should now be considered the gold standard, the initial treatment of choice for our patients with newly diagnosed metastatic colorectal cancer. All right, so what's new? Dr. Vogel had kind of touched on this. Well, if we know it works really well in stage 4 disease, what about earlier stage disease? And he has shown you this another immune checkpoint inhibitor for patients with rectal cancer. And this was the point that he was making, was that every single one of these patients had a complete clinical response, which means that they were diagnosed with stage 2, stage 3 rectal cancer, were given immunotherapy, and then the cancer just disappeared. And that's a pretty phenomenal advance in patients where, well, maybe we don't have to offer them surgery. Maybe we don't have to offer them radiation. Maybe we don't even have to offer them chemotherapy. We just treat them with immunotherapy and their tumor melts away. That's a very, very cool outcome. This also led to a New York Times article that led to about 1,000 different calls to our clinic about dostarlimab. But it's this group that's actually going to receive this type of benefit, right? So. What about in stage 3 colon cancer? The other slide that I showed you was in rectal cancer. This is a study trying to determine if patients with MSI high colon cancer should have immunotherapy added to chemotherapy. The question that we all want to ask is, could immunotherapy just be better than chemotherapy so that you wouldn't have to give these patients chemotherapy? This study will not answer that question. There's also another study now looking at whether or not the addition of chemotherapy in the frontline setting for stage 4 metastatic colorectal cancer can improve on immunotherapy alone. But this is still the standard of care, is to use immunotherapy. Okay, so I'm going to wrap up with this. We're going to go back to our 31-year-old female with stage 3 rectal cancer. She wants to avoid radiation as she really, really wants to have kids, understandably. And so we started with systemic therapy. So this was before the data came out with dostarlimab, which is the data that Dr. Vogel and I both showed you. So what was our best bet? Chemotherapy, right? That was the only thing that we really had at the time. So we started with chemotherapy. And unfortunately, at 2 months after receiving chemotherapy, she's got a new liver lesion. So she doesn't have stage 3 rectal cancer. She has stage 4 rectal cancer. So this is not only a failure, right, of chemotherapy. Well, now the disease is actually getting worse. We switched her to another immune checkpoint inhibitor, pembrolizumab. And there were no side effects, thankfully. We can talk about side effects to immunotherapy later, but the MRI pelvis reveals a complete response to therapy. What does that look like in reality? And Dr. Vogel has already shown you some pretty cool pictures, but this is what the tumor looked like before. And then after that immunotherapy, this is essentially what the tumor looks like now. There's just this scar and there's just nothing there. So this patient is under surveillance, did not get radiation, did not get surgery. And so she's just on this plan where we look with a scope and look with radiologic imaging, and she's doing great. And that's all I got for you. Thank you, guys.